Good afternoon. So welcome back again to this satellite symposium. So we're going to talk about a new era of therapy in treating patients with diabetes, whether type 1 or type 2. So some shed light on the new generation of basal insulin. So as primary care physicians, diabetologists, and endocrinologists, we face lots of challenges in our daily practice when we treat patients with diabetes. So all of you would agree that these are some of the listed challenges that we face, like the increased global prevalence of diabetes, suboptimal control in some of our patients, rate of hypoglycemia, a very concerning issue for you as a treating physician and for patients as well, and also limitation of the currently available insulins, whether basal or bolus insulins. We know that diabetes is increasing globally. It was estimated back in 2017 worldwide to have around 425 million, and this is estimated to increase by more than 600 million by 2045. And as you can see, we are on the top of the list on the regions where the estimation of the risk is probably going to increase by 72%, and that's really huge. And we know that out of the more than 400 million patients with diabetes in 2017, it was reported that 4 million had complications related to diabetes. And we know that the total health expenditure, like for example in diabetes, estimated to be more than $700 billion. So we need to really control diabetes to prevent all these complications and related health care expenditure. So we know that insulin is the mainstay treatment for type 1 diabetics. We know for type 2 you have a broad range of pharmacotherapy or pharmacotherapeutic agents. But ultimately, in some patients with type 2, with progressive beta cell dysfunction, insulin will be required in these patients. But optimum glycemic control still remains a challenge with all the options that you have available. I'm sure most of you agree that still it's very challenging to reach for the optimum control. And looking at this observation retrospective analysis and studying diabetic patients in several countries, European and USA, along with the UK, you can see that the time there is a delay of treatment intensification or even insulinization. And most of these patients, 42% actually, were at HbA1c above 9% when insulin was considered or started. And when these patients were started on basal insulin, they were followed. It was found that at 3 months, only 21% of those started on basal insulin achieved the target glycemic control. And when you look at the end of the period of the follow-up, which was 24 months, 28% only achieved target HbA1c, despite starting these patients on basal insulin. And we know that hypoglycemia, as we said, it's a major concern for physicians as well as patients. But from this study, hypoglycemia occurring in the first 3 months was sort of a prediction for long-term hypoglycemia risk, and it was correlated with the real-world clinical practice. So most of you know how insulin therapy, the evolution of insulin therapy over time. And you can recall the isolation of insulin by Banting and Best back in 1920s. This was like a breakthrough discovery, especially for patients with type 1 diabetes. It was like a life-saving discovery. This was followed by animal insulin preparations. And then it was not until 1940s when NPH insulin was really manufactured, and this insulin was at that time like a big hit, and it was very promising. But At that time, it was not like really the ideal and perfect insulin because it was giving you 12 to 16 hours coverage. And the physicians were told that this kind of insulin needs to be injected twice a day. Then in 90s, we had a breakthrough in discovering the new generation or the first generation insulin analogs, and these were sort of more modified and practically for patients. These were the insulin Ditimer and insulin glargine U100. And with this modification in the insulin structure, it was noted that these types of insulin would give you better coverage, like about 20 to 26 hours coverage, and supposed to be peakless profile. So again, this was something really breakthrough and really changed the way you were approaching patients in diabetes treatment. Then in the 2000s, we came even with better advanced or second generation basal insulin analogs in the 2000s. And the popular two that you know, as you know right now, are insulin glargine U300 and insulin digludec. So these have more, the pharmacokinetic profile of these insulins as actually giving you more prolonged action, lasting for about 36 or more hours, and really flatter line. So this was really a very important discovery in our time as well. So again, when we come back to the hypoglycemia, it's really the limiting factor for insulin initiation as well as intensification. And when we look at this international global attitude of patients and physicians in insulin therapy survey, this was a survey, surprisingly, as you can see, that 72% of primary care were reluctant and hypoglycemia was their main concern in intensifying patients with insulin therapy. And look at the specialists, 79% of the specialists were also concerned about hypoglycemia as a limiting factor for insulin intensification. So when we look at the differences between glargine U300 versus glargine U100, so the U100, for most of you, as you know, it's Lantus, and the glargine 300 is Toujeo. You can see that it's a more sort of concentrated 300 units per ml versus 100 units per ml. So when you look at the glargine 300, you would have smaller volume of injection that really reflects on the pharmacokinetic of the insulin itself. So you are creating a small, actually subcutaneous depot, so you have a smaller surface area compared to the Lantus. So the distribution or the absorption is sort of more gradual and slower release. And this is kind of gives it this advantage of like a uniform absorption and less variability and sort of more a flat line without any peaks compared to glargine U100. We were told many years ago that glargine U100 is sort of peakless, but we discovered from clinical practice it might have a little peak over there, but you don't see that with the U300. And when we look at the glucose lowering profile, when you compare glargine U300 to glargine 100, or even comparing it to the digludec, as you can see here, comparing like Lantus and Toujeo, you can see that the glycemic lowering profile, it's more or less the same, but you can see that it's more flatter profile compared to the glargine U100. Similarly, with the digludec, you can see sort of more flat profile and less variability. Now, what about within day and between day fluctuation? This is actually very important, especially in your type 1 diabetic patients with wide fluctuation. This is actually a big plus for these kind of new generation or second generation insulin analogs. The variability is very few, I mean, in terms of, different glucose levels within a day. So this brings us to the different programs or studies that they were carried out on glargine U300, and we have the addition program, and there are different versions or subgroup populations of the addition program. The objective of addition program was to assess the clinical efficacy and safety of glargine U300 versus glargine 100. This was a randomized trial, 1-to-1, open label, parallel group, and multi-central phase 3 study. So patients were enrolled in 2 arms. Patients were receiving glargine U300 on top of their standard therapy, whether that would be like oral anti-diabetic agents. Similarly to the second group, glargine U100 was added. Patients were followed for 6 months, and there was an extension period of another 6 months. The aim of the study was a non-inferiority to glargine U100, and reduction at 6 months was the non-inferiority at the end of 6 months. So looking at the different addition program, just for you to know, to understand, we have patients with type 2 diabetes, patients with type 1 diabetes. So in type 1 diabetes, we have the addition 4 and addition JP1. This is where the glargine U300 was added to meal bolus insulins in these type 1 patients. The JP was in the Japanese population. For the type 2, we have addition 1, addition 2, 3, and the JP2, which was in the Japanese population. In addition 1, U300 was added as a basal insulin on top of meal insulin. In addition 2, U300 was added as basal insulin plus oral agents. Addition 3, it was basal insulin plus oral agents, excluding sulfonylureas. And this was basically basal insulin plus oral agents in Japanese patients. So looking at across the board for all the addition subpopulation program, as you can see that the study actually met its primary endpoint, which was non-inferiority to insulin glargine U100 in terms of glycemic control. So as you can see across the board, U300 shown not to be non-inferior to the U100 in terms of glycemic, so approximately similar glycemic control. Now, in terms of hypoglycemia, I mean, that's very important. Okay, we know that it's non-inferior to U100, but what about the risk of hypoglycemia? And looking at type 1 diabetics, it showed that there is a reduction similar in terms of incidence of hypoglycemia, even though you can see in the addition Japanese population, it was more in favor in terms of nocturnal hypoglycemia for the glargine 300. But in general, across the board of all addition programs, basically more or less a similar incidence of hypoglycemia. But when we look at type 2 diabetic patients, actually U300 did better in terms of hypoglycemia as compared to U100. If you compare it, whether it's nocturnal hypoglycemia or any time hypoglycemia. So you're having a similar HbA1c reduction to U100, but fewer hypoglycemia risk with U300 in type 2 diabetics. Now, in Bright study was actually different. So a Bright study was a first head-to-head RCT designed to compare the efficacy and safety of glargine U300 compared to insulin degludec 100, which is another second generation basal insulin analog. And in this BRIGHT study, it was a multi-center, open-label, randomized, active control, 2 parallel arm, non-inferiority against study in adult participants with uncontrolled type 2 diabetes. It started with 2 weeks of screening, eligible patients, as you can see, adults more than 18, diabetes duration more than 1 year. The HbA1c at enrollment was more than 7.5 but less than 10.5, BMI 25, and patients could be using oral agents or even GLP-1 agonists but no prior insulin use. So these are insulin naive patients. And then the patients were grouped into 2 arms, patients receiving Glargine U300 once a day and insulin degludec, and with a follow-up period till the end of the study. It's very important in this study that the insulin dosing and titration were followed according to the manufacturing protocol. So Glargine 300 were self-administered, both of them. The starting dose for the Glargine 300 was 0.2 units per kilogram, while in insulin degludec it was 10 units. And the titration was happening to target fasting glucose between 4.4 to 5.6, which is 80 to 100 milligram without hypoglycemia. And this is what we actually tell our patients, in the clinic when you ask your patients to titrate their insulin dose. And this is basically the protocol that all of us follow in the clinic. So the primary efficacy endpoint was change in A1C from baseline to week 24. Again, this was a non-inferiority study. And the secondary efficacy endpoints were to see the change in A1C from baseline to week 12, and then change in fasting, sugar level, and 8-point SMBG profiles, and the variability of 8-point SMBG profiles. And finally, the safety endpoints were primarily concerns about hypoglycemia, whether it's severe confirmed hypoglycemia or nocturnal or anytime hypoglycemia. So if we look at the baseline characteristics, were approximately similar between the 2 groups and 2 arms. Most of them have more or less the same duration of diabetes, type 2 diabetes. Basically similar HbA1c at enrollment. In terms of background therapy, as you can see, the groups were comparable, and most of them were 1 or 2 oral anti-glycemic agents. And as you can see, there were most of them on metformin, SU's DPP4 inhibitor, and SGLT2 inhibitors. So the study, actually, BRIGHT study, met its primary endpoint, which was non-inferiority of Glargine U300 compared to insulin degludec. And as you can see, they have comparable, A1C lowering at the week 24 at the follow-up period. So basically same glycemic control. Now, the most important thing, we come to the hypoglycemia. Again, anytime hypoglycemia, as you can see, it was more or less the same, as you can see, comparing Glargine U300 to degludec, but more in favor of Glargine U300, especially during the titration period from 0 to 12 weeks. What about nocturnal hypoglycemia? Again, as you can see, more or less comparable hypoglycemia rates, but little in favor for Glargine U300 in the titration period, which is from 0 to 12 weeks. So, Glargine U300, for those of you, the brand name is Toujeo, if you are not aware of that. It's a very easy pen to use, and most of my patients who I've started them, or actually even converted them from Lantus to Toujeo, they love it, they love the pen. It has a small thin needle over here, as you can see. It has 450 units of insulin in every pen versus 300 units for Lantus. It's a 1-to-1 unit conversion, so if your patient is on like 20 units of Lantus, you can give, if you want to switch to Toujeo, you can give 20 units of Toujeo. And it has a less injection force, 5-second hold time, so versus 10-second hold time for the Lantus. So, and patients love it. And the injection volume is less compared to the Lantus, as I mentioned. So conclusion of the edition and the BRIGHT studies show that similar glycemic control with Glargine 300 and insulin degludec 100 for HbA1c and fasting sugar levels, modest and comparable weight gain with both treatments despite a slightly higher mean daily insulin dose for Glargine 300 at study end. But by the way, this did not affect the weight of the patients. There was no weight gain with that. Anytime 24-hour and nocturnal confirmed hypoglycemia were comparable between treatment groups during the full study and maintenance period. Anytime 24-hour and nocturnal confirmed hypoglycemia were actually lower with Glargine U300 during the titration period, which was from 0 to 12 weeks. Now, what about renal patients? And that would be very interesting to know, knowing that a quite big number of our patients have diabetic nephropathy, and it would be really nice to see what would be the effect of these second-generation basal insulin at different renal functions. So this was like a subgroup or population from the BRIGHT program itself. So BRIGHT, remember, again, it was comparing Glargine U300 with degludec. Just like a quick thing to know about these programs, in terms of the RCTs, I showed you the EDITION program, but the real world evidence we have, the DELIVER and the LIGHTING, these two also show the non-inferiority in terms of glycemic control when you compare Glargine 300 and degludec. And enlightening program predicted rates of hypoglycemia were lower with Glargine 300 versus the first generation like the U100 and similar to insulin degludec. So these are the some real world studies. So back to these patients with renal impairment or insufficiency. So what they did in these subpopulation of the BRIGHT program, those who were on Glargine U300 and degludec, they looked at different profile of renal function. So all of them in each arm, they looked at patients with GFR above 90, then GFR 60 to below 90, and then below 60. So they wanted to see how these insulin analogs would act in these patients in terms of their glycemic lowering and hypoglycemia. So in the predefined subgroup analysis, there was actually greater HbA1c reduction with Glargine 300 than insulin degludec in those with impaired renal function. And specifically, if you have a patient with significant lower GFR, like below 60, it was actually in favor for Glargine 300 compared to insulin degludec. And in terms of, again, if we look at the change in HbA1c by renal function group, you can see this is GFR above 90, 60 to below 90, and below 60. You can see it was really comparable U300 with degludec in these subgroups, but significantly better for the Glargine U300 if you have a GFR below 60. What about mean daily SMPG and 8-point profile, actually corresponding to the HbA1c lowering effect? And if you could look at across the GFR levels, so here they are comparable. Again, here slightly in favor for Glargine U300, but significantly in favor for Glargine U300 when your GFR is below 60. So when we look at the hypoglycemia, what about hypoglycemia? We showed you the reduction in HbA1c and sugar levels across the day. But what about hypoglycemia for glargine versus digludec? Again, it was shown that the hypoglycemia risk was more or less comparable, but again, the risk was lower in favor of glargine 300 at GFR levels below 60. So the conclusion of this renal subpopulation of the BRIGHT study was that glargine 300 versus insulin digludec in people with type 2 and impaired renal function, there is greater A1C reduction. There were comparable hypoglycemia incidence or rates for the full study period. And I showed you that with even lower GFR levels, more in favor of glargine U300, results could be explained by some differences in insulin characteristics between the two different types of insulin. Further investigation is required to determine if glargine 300 may allow more effective glycemic management in this vulnerable population. Another important aspect of diabetics or subgroup of diabetic patients that most of you would ask are elderly patients. And these are patients above 75. So again, another subpopulation of the BRIGHT study, they looked at the elderly patients and comparing again the glargine with the digludec in patients above 70 years, and at the baseline characteristics were comparable between the two arms. So when we look at the results here, maybe this is not very clear, but this is the A graph represents age less than 65, B above 65, C less than 70, and D, this is the population that we're looking at, which is above 70. And if you look at these subgroups, it's actually comparable in terms of A1C reduction. But the interesting thing that if you have elderly like above 70, actually the glycemic control is more in favor of glargine U300 compared to digludec in this subpopulation. What about hypoglycemia risk? This is showing you the hypoglycemia above 70 comparing glargine to digludec. They were actually very comparable. So the conclusion of the elderly subpopulation from the BRIGHT study, and the key message was that glargine 300 provided similar HbA1c reduction to digludec in older adults with type 2. Apparently greater reductions were observed in those aged above 70. Hypoglycemia risk was similar with both insulins in these older population. So if you are targeting really better control in older population, this might be a very good choice. Now, knowing about all the programs and the trials will take you now to this case presentation. Mr. Salem is a 56-year-old man with an 8-year history of type 2 diabetes. He has unremarkable physical examination. He does a factory job that requires physical activity, and he is relatively fit, but overweight with BMI 28. His blood pressure is 130/85. He's on ACE inhibitor. His LDL cholesterol is 98. And his current anti-diabetic medications are metformin, 2,000 milligrams a day, and SGLT2 inhibitor. At presentation, his A1C is 8.9%. Glargine U100, which is Lantus, once daily 20 units, is prescribed, and he is given instructions about titrating to fasting blood sugar of 120 milligrams per deciliter. Now, the question is, what would be a reasonable A1C goal to set for Salem? A, 6.5%, B, 7%, C, 7.5%, and D, 8%. So who would vote for A? If I can see hands. Okay, what about B? C, and D. So none would say D. So most of you actually voted for B. And we know about the guidelines. I mean, you could be right with A, you could be right with B, and you can even probably be right with C. Now, what the guidelines are telling you and the importance of when you're setting your HbA1c target, it's not like a solid rule anymore. And we're telling you and keep on saying through the latest guidelines that you need to individualize your treatment and even targets in these patients. So it's very important to look at these different factors when you consider whether should I go really more stringent or less stringent with my patient. So you're going to be very aggressive and really optimum control if you reach to 6.5, but is it really ideal for this patient or not? So these are the really factors that you need to consider. Patient attitude and expected treatment efforts, risks potential associated like hypoglycemia or adverse events, disease duration, life expectancy. Also, it's very important whether I should be aggressive or not. Important comorbidities, established vascular complications, your target would probably change, and resources and support system. So really, you have to put all these factors into consideration when you set your HbA1c target for your patient. So for this patient, yes, I would agree, maybe 7% would be reasonable, but it would be good to go to 6.5, provided we are not putting this patient at any risk of adverse events. So now he has A1C 7.5 that he is on Clargine insulin U100. He reports no issues with injecting his insulin, which he gives before bedtime. He experienced mild episodes of nocturnal hypoglycemia, which alarmed him and caused him to stop titrating up his insulin at 32 units daily. And I'm sure you're facing this almost on daily basis on your clinical practice. You give your patient the instructions on how to titrate, they just stop right there, and when you see their fasting sugar, it's still high. They could have gone higher on their dose. But this is one of the factors that limits them. And then the self-monitoring blood glucose on several occasions showed hyperglycemia in the late afternoon. He has gained 3 kgs and the fasting blood sugar remains about 165. So it's very important. Now look at I told you initially that the A1C is 7.5. So you might say, oh, that's good, that's great. I brought him down from 8.9 to 7.5. But there are too many faces for an A1C of 7 or 7.5%. It's very important, and I do that in my clinical practice. I don't rely completely on the HbA1c. You have to correlate your HbA1c with the home sugar monitoring readings, because you could have all these different phases of daily sugar levels for a similar HbA1c. So let's say this patient has an HbA1c of 7%, but look at this patient's profile. 40% of the time this patient is high, 40%. 40% he's in the range, but 20% of the time he's low. So it's true it's 7%, but it's not really a favorable day-to-day profile. This patient, again, for example, he could be, okay, 70% of the time in the range, but 25% of the time he is high, and there is 5% chance of hypoglycemia in this patient. This is like the ideal patient, which would show you really beautiful correlation, more or less most of the time in the range. So it's very important that you correlate. So our patient had a 7.5%. It was a nice reduction, but are we happy with that? He is experiencing some issues here. So what is your biggest concern about Salim's type 2 diabetes treatment? A, HbA1c, which is 7.5%. Is this a concern for you? B, nocturnal hypoglycemia. C, postprandial hyperglycemia. D, weight gain. So who would vote for A? B, C, and D? Yeah, okay. So yeah, I would agree that, I mean, all of them could be like the right answer. Yeah, maybe the A1C 7.5, I'm still not happy with the A1C. Yeah, weight gain, he gained like 3 kgs compared to his previous visit. Postprandial hyperglycemia, we don't know. We were not given that data, that information. We don't have his postprandial levels. But yeah, nocturnal hypoglycemia would be my primary concern. So listen to your patient carefully in the clinic when they come. When you start them on any new agent, listen to their concern and see what is the concern of the patient and your concern just before looking only at your targets and glycemic control. So look, he's telling you that what is limiting him from going up on the dose is the nocturnal hypoglycemia. And that's why he's staying right there at the same dose and still persistent fasting high sugar levels. So how would you adjust Salem's insulin therapy? A, add a prandial insulin. B, change to twice daily dosing with NPH. C, discontinue basal insulin. D, switch to a different basal insulin. So who would vote for A? And who would vote for B? C and D. So most of you voted for D. Now this is because you're listening to this talk, and I'm prepared you kind of with the trials that I showed you about the second generation insulin. But in real life and real practice, I can see most of you here in primary care, and you have probably so far limited access to the second generation. And even in the era when we didn't have these second generation basal insulin, what you have done, you could have probably added prandial insulin. I mean, you would tell the patient, okay, let me take a look at your profile, the rest of the profile. I need to see some of your post-meal levels, and you could probably work that out. Yeah, NPH, maybe most of you would not be really prone to start the patient or put the patient. It's getting really out of fashion now because of the peaks and the hypoglycemia risk again with the NPH. But patients who were on glargine U100 or Lantus at high doses, sometimes, and still we're doing that, we tend to split the dose, right? We would do that, or go with other insulins that you could split the dose. So this is what we were really trying to do with these patients. But discontinue basal insulin, no, for sure you won't do that, because I mean you brought them down from 8.9 to 7.5, but you're here at the fine-tuning stage where you want to achieve your target and at the same time prevent this patient from hypoglycemia. So this is like a typical case if you face, would be really ideal to switch to the different basal, which is like the glargine U300, the second generation insulin. Why? Because more flatter pharmacokinetic profile, less chances of hypoglycemia, as I have shown you from the studies. So you decide to switch Salem from U100 glargine to glargine U300. You put him exactly equivalent. As we said, when we switch, we do 1-to-1 ratio, same dose. So you give him 34 units to start. And you still instruct him to continue to titrate his dose at bedtime to achieve fasting 120. And you tell him that with confidence based on the studies that I have shown you, that it's okay, you can go up because there are less chances of having hypoglycemia with this type of insulin. So at a 3-month follow-up visit, Salem returns and reports no issues with his U300 glargine basal insulin regimen, no issues. No hypoglycemia is reported. He is still taking his metformin and SGLT2 inhibitor. At this visit, his A1C is still, it is the same, 7.5, but you're having a good 7.5% here because his fasting is starting now to improve. He's 125, he's not having any hypoglycemia, and he has titrated his dose and reached actually to 47 units of U300 glargine daily to bring him to a fasting level of 125. So now that you're happy with the fasting and without any hypoglycemia, then the second stage, if you want to optimize the A1C, is to look at your postprandial level and focus, on lifestyle, diet, and all sort of that. So it's very important these factors to consider when you initiate longer acting or concentrated insulin. Facts to consider. Glargine U300 is usually started according to the weight of the patient. So you start 0.2 units per kilogram. Degludec is usually started a starting dose at 10 units, irrespective of the weight. Both insulins suggest a one-to-one dose conversion when switching from NPH or analog basal insulins. Due to the long half-life, titration should be done no less than every 3 to 4 days. So don't tell your patient to titrate every 2 days. It takes time for these kinds of insulin to reach the steady state. So usually the change should be every 3 to 4 days, and you have to instruct your patients to be patient and don't panic in the initial days because it takes time for this insulin to reach a steady state. Due to the long half-life, titration should be done no less, both insulins do not deliver peak effect for several days due to the long half-life. You need to inform patients that they may not see a fully adequate effect for the first day or two. Inform patients maximum effect may not be seen for about a week. That's very important because I see patients calling and panicking, my sugar is still high. So just to calm them down and say it's gonna become okay. In studies, glargine U300 required about actually 10 to 17% higher dosing than glargine U100 comparator to achieve a similar A1C. But really in clinical practice, this was not really corresponded to any significant weight gain despite a little bit increase in the dose over there. Now, the clinical scenarios in which the new generation basal insulins can be considered. I showed you one case here, but these are different scenarios where you can use these new generation or second generation. If basal insulin does not provide a full 24-hour coverage, even if it's that like a glargine U100, recurrent hypoglycemia and nocturnal hypoglycemia, really a major concern, as I told you, for you as a physician as well as for patients. Elderly patients, because you would be worried, they are more prone to hypoglycemia. High-risk patients, such as patients with CVD and CKD. I've shown you the data in the renal patients. Patients with cardiovascular disease, again, they are adding hypoglycemia to their underlying cardiovascular issue will probably aggravate and increase their chance of mortality. And finally, type 1 patients with high today blood glucose variability. Probably most of you would agree, we have seen that in clinical practice. When you switch these type 1 patients to these second generation, really very nice flat line and less variability in the sugar readings. Thank you for your attention.